Before we formally open this event, we would like to put down some reminders. This presentation is being recorded. During the duration of this webinar, kindly turn off your camera and keep your microphones on mute. For questions and clarifications, please type your concerns in the chat box. Our moderator will go through the questions during the open forum. Also, please remember to fill out the evaluation forms before leaving the webinar. A link will be provided in the chat box later. In this breakout session, let us learn about the approach and management of arthritis. This session is headed by Dr. Leonid Zamora. He is an active consultant at the University of Santo Tomas Hospital and is a member of the Fellowship Training Committee in Rheumatology in the same institution. He also published multiple researches focusing on different aspects of SLE. He is currently a member of the APLAR SLE Special Interest Group and APLAR Young Rheumatologist. This session will be moderated by Dr. Jo Rosel Lacson.
Good afternoon, everyone, and thank you to the organizing committee of the First Tiger Internal Medicine virtual postgraduate course for the invitation. I am Dr. Leonid Zamora. I'm a rheumatologist, and it is a pleasure to talk to you today on the more common types of arthritis. I have no disclosures. The outline of my talk for this afternoon is as follows, and I have specifically left out gout in the discussion as it has been thoroughly discussed by Dr. Julie Yu earlier today. Musculoskeletal diseases remain the second cause of YLDs, or years lost to disability, or some people term it as years lived with disability, behind the mental and substance use disorders based on the Global Burden of Diseases Survey 2017. This was published in The Lancet in 2018. Among the musculoskeletal disorders, rheumatoid arthritis, osteoarthritis, and gout have the highest percentage increase in the YLDs from 2007 to 2017. This proves that despite improvement in healthcare access and discovery of new treatments, this chronic forms of arthritis continues to have increased burden to the individual, the healthcare system, and the society as a whole. So it is only proper that we start on how we should evaluate our patients with complaints of joint pains to establish our diagnosis and institute appropriate management early on to prevent disabilities. First, we need to determine the onset of symptoms. Is it acute or chronic? Next is to determine whether the pain is coming from the joint. Is it articular or outside of the joint? Is it non-articular? To distinguish inflammatory type of arthritis from non-inflammatory type of arthritis, and to determine the extent of joint involvement, whether they are mono, oligo, or polyarticular in nature. We also have to know the distribution of joint involvement, whether they are symmetric or asymmetric in distribution, to narrow down our differentials. It is also paramount to elicit systemic signs of inflammation, such as fever, weight loss, fatigue, malaise, etc. And last but not the least, but equally important, is to recognize the red flags or warning signs that the patient's condition is serious and may need further workup and immediate intervention. These are the distinguishing features of articular versus non-articular or peri-articular pain. Articular pain is deep and diffuse. There is painful and limited range of movement on both the active and passive ranges of motion. There is swelling, palpitations, instability, locking, and deformity of the joint. Whereas your non-articular pain is localized with a point or local tenderness. There is painful active movements, but not on passive ranges of motion. The physical examination is remote from the joint capsule and crepitations, instability, and deformity are rare in non-articular type of pains. Now that we are certain that the pain is articular in nature, or meaning that we are dealing with real arthritis, next we need to determine whether it is inflammatory. Inflammatory arthritis would, of course, have the cardinal signs of inflammation, erythema, swelling, warmth, and tenderness, or any combination of the four. Systemic symptoms of fever, fatigue, and malaise, joint stiffness of 30 minutes or longer, and positive acute phase reactants or high ESR or CRP. Your non-inflammatory arthritis, on the other hand, have no cardinal signs of inflammation. Joint stiffness is usually less than 30 minutes, and they may be associated with trauma, repetitive use, or degenerative conditions. Next, we determine the number of joints involved, or the extent of articular involvement. Is it monoarticular, oligoarticular, or polyarticular in involvement? These are just some examples of the common causes. For example, your acute mono or oligoarthritis, you have their gout, septic arthritis, and trauma. While for acute polyarthritis, you have your RA, viral arthritis, and spondyloarthritis, particularly your psoriatic arthritis and reactive arthritis. You can see here that osteoarthritis can be mono, oligo, and even polyarticular in both. We should also take note of the distribution of joint involvement, as some arthritis have patterns of joint involvement. Particularly, rheumatoid arthritis have a symmetrical polyarthritis pattern. Psoriatic arthritis, however, has a asymmetrical oligo or polyarthritis, and some may involve the spine, like what we see in patients with ankylosing spondylitis, rheumatoid arthritis, and even osteoarthritis. Last but not the least, again, we have to take note of the different red flags or warning signs because this may signify a more serious form of arthritis that may need further evaluation or immediate intervention. So if the patient has persistent or worsening pains and pains unrelieved by regular intake of your NSAIDs or other potent analgesics, those with temporal headaches or visual disturbances, those with loss of sensation and or motor functions, difficulties with the urination and defecation, accompanying fever, weight loss, and pallor, and patients who are elderly. So this figure shows the practical approach to arthritis. Now this is a diagram, and first it's very important for you to have a very good history and physical examination so that you'll be able to determine whether this is articular in origin. Okay? If inflammation is present in one joint involvement or one joint, or there's involvement of one joint or monoarthritis, the main differential is gout, septic arthritis, trauma, and at times reactive arthritis. If it is inflammatory polyarthritis with prominent spine involvement, then ankylosing spondylitis and psoriatic arthritis are the most common differentials. Those with inflammatory polyarthritis with minimal or no spine involvement would include your RA, parallel arthritis, and even SLE arthropathies. Meanwhile, those articular arthritis with mild to no inflammation, might point to osteoarthritis in origin. Again, after determining whether it's articular or non-articular, inflammatory or non-inflammatory, we look at the red flags or the warning signs. If it is absent, then probably the joint pain is benign and would just need symptomatic treatment. However, if any of the warning signs are present, then it can be potentially serious or may need further workup um, after giving our symptomatic treatment for our patients. Or these patients might need referral to other specialists for further evaluation. So after that approach, brief approach on patients with arthritis, then we now have our case studies. I present to you a 65-year-old female who's overweight, but generally with good state of health. On and off knee morning stiffness for 10 minutes for 2 years with no observed swelling or warmth. On history, there was diffuse pain over the left knee for 7 days, affecting her ability to walk and preventing her to go up and down the stairs. She denies numbness, weakness, nor shooting pain, and she only takes paracetamol 500 milligrams 3 times a day with minimal relief. An examination of the left knee, there was moderate effusion at the anterior superior aspect of the knee joint and smaller sides of the effusion at the medial superior aspect of the knee, and it is tender to palpation. There was also pain on the passive flexion and on walking. There was noted crepitations on palpations of the knee on flexion and extension movements. So our first question, what is your diagnosis? We already know the onset is quite acute for 7 days. However, she has morning stiffness for more than 2 years. Okay, so first question, is it articular? And the patient presented with diffuse pain of the knee. There was a pain on the passive and active ranges of motion. On history and even on physical examination, there was swelling of the joint and crepitation. So at this point, we're certain that we're dealing with an articular type of pain. So is there inflammation? So I think that this patient has mild inflammation. We have mixed inflammatory and non-inflammatory symptoms and signs, right? She has some form of inflammation as manifested by effusion and tenderness on the left knee on palpation. However, there are also information that tells us that 2 years ago or prior to the 7 days prior to this, her morning stiffness was just less than 13 minutes or 10 minutes a day for the past 3 years. So it tells us that probably there is mild inflammation that is going on with this patient. There was no history of trauma and no noted degenerative conditions. So next is what is the extent of joint involvement? So there's only one knee involvement, one knee, that's the left knee. So we have a monoarthritis in this case. Again, your monoarthritis differentials could be gout, septic arthritis, trauma, and look there, no? Can be early rheumatoid arthritis and even osteoarthritis. So looking at the diagram again, so we're sure that this patient has articular pain, inflammation, we're not so sure. We label this patient as having mild inflammation. If there's mild inflammation, one of the consideration is osteoarthritis, but this patient has monoarticular pain with some form there of, of, um, of of inflammation. So still, I would think and put on my differentials gout and septic arthritis at this time. So next is look at the red flags. Do we have red flags in this patient? Yes, we do. She's elderly, no, more than 60 years old. And also she has persistent pain despite treatment with your paracetamol of 500 milligrams 3 times a day. So it's potentially serious and probably would need further workup for us to clinch the diagnosis at this time. So, okay, this is the red flags, persistent worsening pains and elderly. So what is our working diagnosis? Yes, these are the three working diagnoses that we have for our patient. On the top of our list is osteoarthritis. Still the primary consideration because of the risk factors of age, overweight, and mild inflammation that were noted, plus the morning stiffness that was noted prior for 2 years. that is non-inflammatory type of morning stiffness. There's diffuse pain over the left knee for 7 days, correct? There was, however, moderate effusion in her left knee with a large, uh, it, which is a large accessible joint. And if you have effusion in an easily accessible joint, a rule of thumb is always to aspirate that joint and obtain the synovial fluid and examine that synovial fluid. In this case, we were able to aspirate 20 ml of transparent yellow synovial fluid with cell count of 500 WBC per millimeter cube, and the gram stain was negative, and no crystals were seen on polarizing microscopy. So this excludes our other differential diagnosis of crystal-induced arthritis and septic arthritis, and confirms our primary impression of osteoarthritis in this case. So just to review you of the synovial fluid characteristics, we take note of the clarity, color, viscosity, the WBC count, and the number of PMNs to differentiate between non-inflammatory, inflammatory, septic, and hemorrhagic types of synovial fluids. Depending on the clinical scenario, synovial fluid is analyzed again for cell count and differential count of crystals and culture and sensitivity and cytology if malignancy is also considered. So let's go to osteoarthritis. Osteoarthritis is a condition found worldwide and is strongly associated with aging and is the most common type of arthritis. Symptoms would include pain, discomfort, transient stiffness, cosmetic deformities such as your Heberden's nodes and Bouchard's nodes, a reduced function, weakness, grinding or crepitations, and instability or buckling of the knees. Because of its effect on ambulation and mobility, osteoarthritis of the knee and hip has significant functional impact and is associated with considerable medical costs. Risk factors that are strongly associated with the incidence of knee osteoarthritis can help to identify patients in whom knee osteoarthritis is the most likely diagnosis. This include increasing age of more than 50 years old, female gender, higher BMI, previous knee injury or malalignment, joint laxity, occupational or recreational usage, family history, and the presence of Heberden's. Knee osteoarthritis is characterized clinically by usage-related pain and or functional limitation. It is a common complex joint disorder showing focal cartilage loss, new bone formation, and involvement of all joint tissues. Imaging provides a great deal of structural information in osteoarthritis. It is important to remember, though, that the radiographic changes of osteoarthritis occur only after the degenerative process has been ongoing for several years. Remember that your cartilage is radiolucent, and the radiographic appearance of cartilage degeneration would be radiographic joint space narrowing, which requires a great deal of cartilage loss before it is evident radiographically. Similarly, subchondral sclerosis and osteophyte formation occur as a response to a long-standing structural processes, including inflammation. Thus, individuals may have symptomatic, clinically significant osteoarthritis for several years before developing a radiographically evident changes. Hence, the diagnosis of your osteoarthritis is a clinical decision. There are no laboratory tests that are sufficiently sensitive or specific to aid in the diagnosis of your osteoarthritis. And the principal utility of the clinical laboratory is to exclude other etiologies of these symptoms of the patient. There are recommended therapies for the management of osteoarthritis. Strongly and conditionally recommended approaches to management of hand, knee, and or hip osteoarthritis are the following. Um, the various options here may be used and reused at various times during the course of a particular patient's disease. A comprehensive, a comprehensive plan for the management of osteoarthritis in an individual patient may include educational, behavioral, psychosocial, and physical interventions, as well as topical, oral, and intra-articular medications. Treatment decisions should take the personal beliefs and preferences of the patient, as well as the patient's medical status into consideration. There are three things that I would like to emphasize in the management of osteoarthritis. First is, though exercise is strongly recommended for all osteoarthritis patients, there is considerably more evidence for the use of exercise in the treatment of knee and hip osteoarthritis for the hand osteoarthritis. So, exercise recommendations to patients should focus on the patient's preferences and access, both of which may be important barriers to participation. If a patient does not find a certain form of exercise acceptable or cannot afford to participate or arrange transportation to participate, he or she is not likely to get any benefit from the suggestion to pursue that exercise. So, what kinds of exercises should we recommend? Aerobic, strengthening, aquatic exercises are the most studied. In the majority of studies that assesses the role of aerobic exercises in the management of osteoarthritis, walking was the most common form of exercise evaluated, either in a treadmill or as supervised community-based indoor fitness walking. Other studies have used supervised group cycling or stationary bicycles. Strengthening exercises have included the use of isokinetic weight machines, resistance exercise training with and without props, such as elastic bands and isometric exercises. Neuromuscular training has been developed to address muscle weakness, reduce sensory motor control, and functional instability, specifically seen in patients with knee osteoarthritis. Aquatic exercises often encompasses aspects of aerobic fitness exercises and exercises for enhancing joint ranges of motion in a very low impact environment. Second thing that I would like to emphasize in the management of your osteoarthritis is weight loss. And weight loss is strongly recommended for patients with knee or hip osteoarthritis who are overweight or obese. A dose response has been noted with regard to the amount of weight loss that will result in symptom or functional improvement in patients with osteoarthritis. A loss of around 5% or more of body weight can be associated with changes in clinical and mechanistic outcomes. The efficacy of weight loss for osteoarthritis symptom management is enhanced by the use of the concomitant exercise program that the patient will enroll into. Third, that I would like to emphasize is on the self-efficacy and self-management programs. This is, again, a strong recommendation for patients with knee, hip, and or hand osteoarthritis. The benefits of participation in self-efficacy and self-management programs are consistent across all studies, and risks are very minimal. These programs use a multidisciplinary group-based format combining sessions on skill building such as goal setting, problem solving, and positive thinking. Education about the disease and about the medication effects and the side effects. Joint protection measures and fitness and exercise goals and approaches are also included in the self-management programs. Okay, so that's for our first case study. That's an elderly female with mild monoarthritis. Ultimately, we diagnosed her as osteoarthritis and we gave you a brief background on osteoarthritis and the management of osteoarthritis. So now we proceed with the second case, which is of a 37-year-old female who has a pain and tenderness of the metacarpophalangeals and the PIPs of both hands for 2 months now. She also has morning stiffness that lasts for 2 hours and has associated fatigue and malaise. The pain is partially relieved by celecoxib, 200 milligrams twice a day, from a BAS score of 8 over 10 down to 5 over 10 with the intake of the celecoxib. She also has a 10 pack years of smoking history. On physical examination, she was positive for the squeeze test. And on further examination of the hands, there was tenderness over the metacarpophalangeal joints, 2 to 5, and the proximal interphalangeal joints 2, 3, 4, and 5 of both hands. The MCPs and the PIPs that were involved were warm and tender on passive and active ranges of motion. So what is our diagnosis for this case? First, is it articular? Yes. She has diffuse pain, tenderness, and limited passive and active ranges of motion. Second, is it inflammatory type of arthritis? Yes. She has stiffness of more than 30 minutes, 2 hours to be exact. There was warmth, tenderness, and even systemic symptoms of fatigue and malaise. What is the extent of joint involvement in this patient? It's polyarticular, it's symmetric. Both hands, the MCPs and the PAPs of the both hands are involved, and it's acute or chronic. It's been chronic. It's more than 6 weeks, and to be exact, 2 months in duration. So when you're presented with a patient with chronic symmetrical inflammatory polyarthritis sparing the distal interphalangeal joints, only involving your MCPs and PIPs, your main or primary diagnosis would always be rheumatoid arthritis. Rheumatoid arthritis is the most common inflammatory arthritis worldwide with a global prevalence of 0.5 to 1%. Smoking is the best defined risk factor for rheumatoid arthritis, and studies have shown that it induces the peptidyl-arginine deaminase, or your PADI, enzyme in the lungs to result in the citronation of arginine residues of different antigens. Interaction with genetic susceptibility genes, particularly HLA-DR, increases the risk of development of RA as well, leading to protein modifications, which are recognized by the EPCs, or your antigen-presenting cells, the dendritic cells, and the macrophages, and the fibroblasts, like synovial that lead to the activation of your innate and adaptive immunity, resulting to the production of inflammatory cytokines. Among those cytokines, TNF alpha plays a major role in the pathogenesis of rheumatoid arthritis as it modulates the release of other pro-inflammatory cytokines, acute phase responses, bone resorption, and ultimately cartilage destruction. The main presenting symptoms of rheumatoid arthritis include swelling and tenderness of the joint and the joint margins, systemic symptoms of malaise and fatigue, and most prominent is the severe morning stiffness. Patients with long-standing disease with high titers of rheumatoid factor can develop extra-articular manifestations involving the heart, lungs, vascular, neurologic, eyes, and the skin. In 1987, the ACR made a classification criteria for rheumatoid arthritis to aid in the diagnosis of rheumatoid arthritis. At least four of the following criteria must be met. Morning stiffness lasting more than 1 hour, swelling of more than three joints, swelling of hand joints, and symmetric joint involvement all should be present for at least 6 weeks. There should be radiographic changes, erosions from bony decalcifications, presence of rheumatoid nodules, and factor positivity in the serum. Note that radiographic changes in the presence of rheumatoid nodules are seen only in established rheumatoid arthritis or long-standing rheumatoid arthritis. Therefore, sometimes this classification is very sensitive for established rheumatoid arthritis, but not for early rheumatoid arthritis, which is the paradigm now. To diagnose those early rheumatoid arthritis, the ACR had a revision of the classification criteria in 2010 for rheumatoid arthritis. So this includes four domains here. You have joint involvement, serologies, acute phase reactants, and duration of symptoms. So you have to have synovitis of at least one large joint or two large joints, I mean two joints, to up to more than 10 joints, and it is scored accordingly from 0 to 5. Serologies were included, such as your rheumatoid factor and the anti-citrullinated peptide antibodies. Whether they are low and high, RF and ACPA positivity, they are scored as 2 or 3. They also included the acute phase reactants, CRP and ESR, and of course retained the duration of symptoms of 6 weeks. So you need six to score a definite rheumatoid arthritis in this classification criteria. And this has been noted to be more sensitive in terms of diagnosing rheumatoid arthritis early on the disease onset. The goals of therapy for rheumatoid arthritis is, of course, the treatment should be aimed at reaching a target of sustained remission or low disease activity in every patient. So for patients who are DMARD naive or those who have not taken DMARD such as methotrexate, sulfasalazine, hydroxychloroquine, aim is always remission for these patients. However, in patients who have failed previous therapies, they should at least be put into low disease activity if they cannot be put into remission. And this target should be sustained for at least 6 months in order to have a better outcome for the patient. The current therapies, of course, is on symptom control. We have this very good anti-inflammatory agents of NSAID and corticosteroids. However, they do not modify the disease course of rheumatoid arthritis. Therefore, it is important for us to institute early on the DMARDs or the disease modifying anti-rheumatic drugs, such as your methotrexate, hydroxychloroquine, sulfasalazine, monotherapy, or in combination of three. Some would use the flunomide, but due to its lack of access and availability in the Philippines, there's a lower use of leflunomide in the region. Other disease-modifying therapy include your TNF inhibitors. As we've seen earlier, your TNF alpha plays a major role and is central into the pathogenesis of your rheumatoid arthritis. And therefore, TNF inhibitors were used early in the 1990s with infliximab, first administered in 1992 for rheumatoid arthritis, and it was followed by your etanercept, certolizumab, adalimumab, and golimumab. The other biologics or other mechanisms of action that have been used for rheumatoid arthritis are the following. You have your rituximab here, your abatacept or abatacept, tocilizumab, your interleukin 6 inhibitors, and your JAK inhibitors. And lastly, free-to-target approach is the way to go in terms of managing our patients with rheumatoid arthritis. But it is also equally important to engage our patients to be proactive in the treatment. So you have to establish that good doctor-patient relationship, and we have to remember that it is built on trust, and they will be able to trust you if you can give them truthful information and options in the management of their rheumatoid arthritis, and to engage them to decide and look for the individualization of their treatment based on their preferences and on their therapies. Because it is noted that when patients are more engaged with their treatment, it improves their health outcomes. And in summary, hopefully that I've given you the different important um, things that you need to evaluate patients with arthritis. And it starts with a good history and physical examination. Um, I've given you the features on how to distinguish articular versus the non-articular pain, and distinguishing inflammatory versus the non-inflammatory arthritis. And always remember the practical approach to the arthritis diagram that I've shown earlier. Osteoarthritis, remember that it is a chronic non-inflammatory to mildly inflammatory type of arthritis, and that age is the strongest risk factor for your osteoarthritis. In terms of management, your weight loss, exercise, and self-management programs are vital in the management of osteoarthritis. Rheumatoid arthritis is one of the most common inflammatory arthritis and one of the major causes of your years lived with disability in the world. Smoking is the strongest risk factor for rheumatoid arthritis, and remission or low disease activity is the treatment target for rheumatoid arthritis. And always remember to engage your patient and have a shared decision making in terms of treating and managing your arthritis patients, because shared decision making improves outcomes. And with that, I end my discussion, and thank you. And I hope that some of you in the future would join the UST-IM rheumatology. Thank you and good day.
In this next lecture, we will learn about the different dermatologic manifestations of common medical disorders. This will be discussed by Dr. Eleanor Letran. She is a dermatologist currently practicing in the University of Santo Tomas Hospital, Cardinal Santos Medical Center, and Chinese General Hospital and Medical Center. She is currently the Vice President and Board Member of the Philippine Wound Care Society. She is also an Associate Professor of the University of Santo Tomas Faculty of Medicine and Surgery, Department of Dermatology. This session will be moderated by Dr. Jo Rosel Lacson.
Sige po, Doc. You may start po, Doc.
Okay, 1, 2. I'll just put a timer on myself so I'll know then how far and I am.
Sige po, Doc.
Good afternoon. Today, my name is Dr. Letran. I am supposed to handle the skin manifestations for internists. and I entitled it to The Wounds and the Internist. The objectives for today is for us to review some concepts of wound healing, and hopefully that we'll be able to apply it on 2 medical cases that we showed for wounds. And then hopefully that you'll be able to appreciate the importance of wound healing concepts as applications to the management to your patients as you utilize a multidisciplinary team approach to your patient. So we have a 74-year-old hemiplegic who came in because of cough. And on further physical exam, you saw this ulcer on the sacral area. And upon prodding, you note that they have poor repositioning at home with poor nursing care. So let's ask a question to yourself. What is your diagnosis? Is it A, decubitus ulcer, B, pressure ulcer, C, pressure injury, D, chronic wound? You may answer to yourself. No one's going to gauge. The diagnosis is pressure injury. The term now, the archaic term of decubitus ulcer, as well as the later term of pressure ulcer, has now been changed to pressure injury for obvious reasons, because not all have ulcers. Some of them still have the epithelium intact. So actually, pressure injury is still a localized damage of the skin and its underlying tissue, and can go down deep into the fascia, muscle, and even to the bone. And it's usually related over bony prominence or even to a medical device. So these are the common pressure sites that you should be familiar with, so that when you take care of your patients, you'll be able to see that these are the sites of predilections of pressure injuries. Aside from doing a initial diagnosis, you have to stage it. So what is the stage of this injury? Is it a stage 2, a stage 3? Is it a deep tissue injury stage? Or is it an unstageable stage? So you might pick one for now, okay, and then we'll go through them. So as you know, the stages of pressure ulcers or pressure injuries, initially in the olden days, there were just 4 stages, stage 1 to 4, but now they have added 2 more. The suspected deep tissue injury, as well as the unstageable. Let's go through them fast, one by one, as a review. So stage 1 is the basis is the erythema or the redness. The most common thing that most clinicians use is their fingertip as they touch on to the area. If it blanches, the redness blanches, or it doesn't blanch. If it doesn't blanch at all on a pressure injury area, then this is what you call the stage 1. And the basis is erythema and on an intact skin, okay? Now, on stage 2, now you now have some partial loss. You will now be seeing the dermis. So usually it's in the top or middle dermis that's eroded and has become ulcerated. Sometimes you may initially see a blister before this partial thickness loss will occur. So this is what you call your stage 2. The stage 3 is now more full thickness, and now it goes down deep into the dermis, into the adipose tissue. And of course, stage 4, this is a full thickness, which now goes down deep beyond the subcutaneous tissue, going down to the fascia, even to the muscle. Stage 3 and stage 4, you might even have undermining or tunneling that is might be present in those wounds. The unstageable, on the other hand, is you have now an obscured full thickness, wherein you have slough and you have eschar formation. So once you see that, you will not be able to know as to how deep the injury really is. So that's the one that you call unstageable at that point in time before you do your proper debridement of the lesion. Deep tissue injury should be differentiated from a stage 1. Stage 1 is usually erythema, but this one is a non-blanchable, this time maroon or purple colored. So it almost looks like a hematoma. I'm sure you've seen a lot of this, and sometimes you might mistake it as a stage 1. So this one is what you call deep tissue pressure injury. So for our case, the answer is the unstageable. As you can see, a deep eschar and slough forming, and you don't even know if it's tunneling underneath. So what you have to do is to have to remove that and see how deep it is. Aside from the 6, there are also what you call the medical devices related pressure injury, or what you call the mucosal membrane pressure injury. For medical devices, you can still use the pressure classification. But however, if you're now dealing with the mucosal membrane injury, you don't need to use the pressure classification. This is just more for completion for today. So which one of the following is least useful for you when you are now assessing a pressure injury on a darkly complexioned patient? Remember, as Filipinos, we have a range of colors. We have the mestizas down to the very dark people, no? Almost very black looking. So if the darker you are, the erythema now starts to get a little bit blurry. So the stage 1 and the unstageable is or a deep pressure injury is a little bit harder to assess. So which one is the least probable? So is it the redness, the pain, the skin temp, or the skin moisture? As an additional consideration for darkly pigmented individuals, it's hard sometimes to just rely on the erythema alone, especially if you have a darkly pigmented patient. So I would suggest, or they suggest, that skin temperature, subepidermal moisture, change in tissue consistency, such as the bogginess of it, a presence of localized skin pain, which will speak more of an ongoing infection also underneath. You have to adjust to those things also as an added features for you to assess. So as you assess further, aside from staging it, you look at the size, the location, all right? The exudates that are coming out is very important. The amount, the color, that will give you clues as to what type of exudate you're dealing with, the tunneling and the underlining, and the presence of slough, the eschar, fibrin, pus, granulation. The edges of the wound is very important. Let's say, for example, you have callus or rolled borders, then you have to check with your surgeons because in reepithelialization, the edges will have a hard time if you have those things. And of course, your hyperemia, excess redness, swelling, pain, and tenderness will speak more of an ongoing active infection. So you have to deal with that. A caveat is the association of an on top of the pressure injury would be the incontinence associated dermatitis. This is due to sometimes feces or urination. You know, the patients are just exposed to it. And so these are the sites of predilection. You will see it in the entire buttocks, in the entire middle thighs and pubic area, and of course the genitalia area will be very, very moist. And in order to differentiate it from your pressure injury, the incontinence dermatitis is usually more pink and more red. They're rarely necrotic at all. They don't usually develop slough or eschar at all. And of course, they are diffusely distributed as the previous slide as I've shown you. So here you can see the area wherein they're moist, red, but there's no, this is more of the incontinence dermatitis. So with the pressure injury management, of course, it's in general, you have to be, what is the primary intervention that you should do? And that is, of course, to reduce pressure, no? And the shearing forces and the friction involved in pressure management. So this, a good nursing team would really help you, a good education to the patient's relatives or whoever's taking care of the relatives should be given, all right? That is beyond the scope of today's lecture though, but nonetheless, I think you are more familiar with that. With regards to the concepts of wounds, as I've said, we have acute wounds and chronic wounds. And chronic wounds is definitely those wounds that just fail to progress. Pressure ulcer falls under usually on the category of chronic wounds. And so what happens is instead of remodeling on time, in chronic wounds, it becomes a vicious cycle and it just goes on and the wounds just don't heal. The concept behind the wound healing per se, no? Aside from knowing the risk factors of your patient, why they are not being moved and so forth and so on, is the time concept in wound. If you look at this slide, this very busy slide, the clinical observations on the left, as you can see, this is your tissue or non-viable or deficient tissues. That's your T for time. Then we also deal with the infection and the inflammation, the moisture of the wound, and the edges, the wound edge, no? And the undermining. So if you have, let's say we go back to the letter T, a non-viable tissue, you have dead tissue there, necrotic area, what you have to do is to remove it. And usually debridement is one of the ways to remove it. And for that, we will be able to restore your wound base, and then we'll have a viable wound base at the end. With regards to infection and inflammation, high bacterial counts or inflammation prolongs wound healing. So, of course, we need to remove it. If it's an overt infection, then of course you give your antimicrobials. But later on, you will see that in wounds, there is this subclinical infection that's going on. So you have to remove the foci there, and hopefully that you will be able to lower your bacterial counts and then have a reduced inflammation and bacteria. With moisture balance, in terms of wound healing right now, the old concept of desiccating and drying is long gone. And most of the time now, it's moisture, but not excessive moisture. I would like to call it turn it into a moisture balance, not too wet and not too dry. So because desiccation will definitely slow down your epithelial cell migration, and excessive fluid also will cause macerations on the margins. All of these, you have to restore the balance in order for you to have a restored epithelial cell migration. And then so that you will also avoid edema and excessive fluid control. So with this, here you will need a lot of things in order for you to decrease your moisture. And one of the important armamentum right now are dressings, good dressings that can absorb all these exudates. Sometimes we may use compression if you are dealing with lymphatic problems also. And sometimes our surgeons, after debridement, and if there's a lot of exudates, we can use the negative pressure instruments for this. So all of these, at the end of the day, what we want is moisture balance. And of course, the edges, as I've said, you will have to reassess it. Do you need some debridement? Do you need some things that you will do that so that you will have good migrating keratinocytes that should go and restore the edges for your advancing wounds. And that is what you call the time concept. So we now have, knowing and reviewing the time concept, we now know that we need to prepare a proper environment for our chronic wounds. So in terms of preparation, you will need to manage by removing your necrotic tissues, decrease the bacterial load, prevent the wound drying, and prevent excessive exudates, and as well as you have to treat the undermining and wound margins. So all of these, we practice the time principles with the result of what we want is to have tissue viability, infection or inflammation control, and moisture balance, as well as epithelial edge advancement. So again, for your wound preparations, what we will do is you can order for some type of debridement. You may call on your colleagues for this, or if you want to do it yourself, it depends on your capabilities. But definitely there are sharps, there are autolytics, chemicals, down to biologics debridement that is available. An important thing that we have to concept that we need to address in chronic wounds is biofilms. As you can see in this slide, the biofilm occurs during the time of a colonization down to the local infection, down to the spreading infections down. What is a biofilm? It is a distinct state of a microbial infection. It is very host interactive and a polymicrobial at that. It is very self-sustaining and self-assembling. And the problem is it is very tolerant to antimicrobial therapies. So even if, let's say, for example, here in the critical colonization and localized infection, wherein biofilm plays a very big role in wound healing, wherein sometimes you're already giving everything and then you notice that your wound is not healing, think of biofilms. They may be there and they are critically impeding your wound healing, especially during critical colonization and localized inflammations. So here with biofilms, things to think about is how come my antibiotic is not doing well? If you did give it, infections of more than 30 days of duration, you have a friable granulation tissue. Some authorities believe in this, that there is some sort of like a gelatinous material that is easily removed that quickly rebuilds. Some authorities, though, say that you cannot see biofilm. So, but for wounds, they say that this might be a clue that if you have this gelatinous material, that you are dealing with a biofilm. So basically, debridement actually helps to physically disrupt and remove the biofilm per se. And then, of course, your topical antimicrobials can help you with this further for your wound contamination. So basically, they are used to manage antiseptics. Sometimes, if there is microbial resistance, sometimes they say that it's even more beneficial than the antibiotics because of these biofilms. So here are some just of the common antimicrobials that are being used. So as you can see, a lot of people like to use mipiricin, but if you can look at mipiricin, it's only an anti-MRSA. And so it's a very poor and a very narrow antimicrobial spectrum to be using on such. Okay. And this is Povidone Iodine. It builds the advantage is that it's no resistance. However, you have to have some cautions. And there are different types of Povidone Iodines now in the market. Some of them are slow release and so forth. So you can use those. Those are very nice. Those are better. Okay. So our healing objectives actually is if you have a local infection, you clear your infection. If you have a dry eschar, then you have to soften this and remove it. Wet necrosis, you have to dislough it. If you have a lot of granulation and a lot of exudate, you have to absorb all those exudates and protect the granulation tissue. And if you're now reaching the neoepidermis, you have to protect this epithelialization. Dressings have now become an armamentum, an added armamentum by physicians, both by dermatologists and by surgeons. And because there's now a gamut of dressings around. So for local infections, those dressings that have silver seems to help. Those that you can make the dry eschar a bit better, you can use the hydrogels. If you have wet necrosis, you can use your alginates and your hydrofibers. If you have granulation tissue, the foam dressings would be good. Your neoepidermis, you might use your hydrocolloids. That would be good. So there are different types of dressings. Here, dressings, if you are going to use it for exudative control. So here are the different types of dressings. So it's not just this type of dressing that we usually see in the market. There are a lot of dressings out there to choose from. Right now in the Philippines, there's a lot of companies that have already come in, and there's a lot of dressings that are involved, and you just have to get used to the type of dressing that you like and use them for whatever purposes that you think that they should be able to help you with. And here again is another guide for dressing choices. So you can help, they might help in debriding, disloughing, managing the exudate is actually the major role. And of course, maintaining of the moisture and protection. And here is, of course, for pressure ulcers, the good turning schedule is very important, as well as some other things of offloading devices that you can use. And if you have an incontinence-associated dermatitis, these are the things you have to cleanse it well, and of course, protect with a barrier. The moist concept is also being used in the sense that for control. So for example, moisture balance, again, you may use for dry wounds and moist wounds. These are your examples to use. Oxygen, sometimes some surgeons, there's like your hyperbaric if chronic wounds are in need of it. I've already talked a little bit about the infection and the role of biofilms. And so here the antiseptics are being used, the silver-coated wound dressings. Okay, the support such as your growth factors for chronic wounds, epidermal growth factors are sometimes being used for this. And of course, your cleansing is important, and the debridement choices. Of course, at the end of the day, if you have patients that are risk factors for pressure injuries, you have to have some preventions being done. And this is done by this busy slide is actually, you can see it in the net. This is by the National Pressure Ulcer Organization. And it involves your risk assessment, your skincare, your nutrition, and of course, the repositioning and mobilization. should be the major part of a prevention of pressure injury. And I would like to just introduce you to this international guideline that was finished in late 2019. So this is the latest, wherein you have the European ulcer, the National Pressure Ulcer, and the Pan-Pacific Ulcer Injury Guideline for this, that you can probably get from the net or download, but I think you have to buy it. I was one of the small committees there, so I think it's a good read. All right. So here, we now proceed to the second case of a 44-year-old female who has dysuria, dysphagia, and macular rashes. Wherein 4 weeks ago, he had elevated uric acid and was given allopurinol 20 days ago. She presented with leukocytosis, low-grade fever, and this is what she looks like. So you have these generalized dark red maculopapular eruptions going generalized, and then later on turning into coalescing with blisters, and then now sloughing off. Okay, and of course the eyes, you will see it, and the nose with the crusting, and the vulva with erosion. So this is, I think, an easy case of, not easy case, but an easy diagnosis of Stevens-Johnson TEN, or a toxic epidermal necrolysis. Of course, the main treatment is, if you can withdraw the offending drug, best. As you can see, there are some options that are being used, but on a STAR mode, the supportive care is most important, which is the target of my lecture for today. So what are the supporting strategies that you can use? So of course, a hospital setting is best, wherein patient is placed in one solo room, wherein nursing care sana is 1:1, and with a good humidity within. And so aside from all the other cares of pain management, ocular, oral care, the wound care, as I will emphasize for today, will be the one that we'll talk about a bit more. So again, going through the time concept, hopefully we can apply, but this time now with TEN and SJ, these are more acute wounds, more rapid, and wherein you have now a goal in wound care. So what is the goal in wound care is, of course, to prevent further mechanical trauma to the skin by protecting the underlying exposed dermis, since SJTEN is more of an epidermal in nature. We want to minimize skin infection, manage the exudate, and prevent maceration and trauma. And then you reduce, hopefully, the scarring process, pigmentary changes later on. And we would like to optimize the condition for reepithelialization. The problem with SJTEN in wound care is because there's lack of randomized clinical trial because of the, there's not much people undergoing SJTEN, thankfully. But then, of course, with that, we lose a lot of large-scale clinical trials. So, question. Which of the following is a recommended treatment practice in SJ wound care? Is it to treat the skin like a burn injury? Can we use high-velocity normal saline debridement? Do you do the aggressive surgical debridement of epithelial detachment? Or do you leave the epithelial detachment on the patient? So the recommendation by dermatologists is that SJTEN is not exactly like burn. So unlike the burn guidelines, wherein you really go for, removing the necrotics, the debridement, etc., the dermatologic expert panels favor a conservative approach in the sense that you at least try to preserve detached epidermis, hopefully using it as a biologic dressing, as we know that the mechanisms of burn and SJTEN is different. So what is the recommendation? First, what you have to do is to determine the percentage of body surface that is affected. When you say that it is affected, what we are talking about here in SJTEN is not just the maculopapular eruption, but it's the detachment. The one that is necrotic, the one that has positive Nikolsky sign, that's the one that you are picking on. The percentage of BSA is not the entire thing in the sense that, if you just have the rashes, but it's more of the epidermal detachment. You try to avoid unnecessary manipulation as much as possible. If the thing is there, your skin is still intact, but it's already bloating like bullays, or you know that it's sloughing off, but it's not yet totally slough off, try not to manipulate it. Minimize all frictions. Maybe you can use nice beds there or fluidized beds if you have it. When you clean it, use sterile water, normal saline. You dilute or a dilute chlorhexidine, I'm sorry, 0.05 solution. And, as much as possible, if you can use the detached epidermis, and just retain it there if you can, that would be best. We may remove the bullae, or what do you call this? Lyse the bullae a bit, but it's more for comfort. Generalized wound debridement is not really recommended. Okay, so you can use now your dressings here. In general, don't use adherent dressings, those dressings that have adhesives. So don't use that. Your duoderm will not cut it. Your hydrocolloid dressings that are adhesive will not cut it. Okay, so don't do those. Use a non-adherent sterile dressings. Some like to use, one of the more famous ones is those silver impregnated, but they are expensive. You can use that as a primary dressing, and then over that, use a secondary dressing for absorption. So here are studies of different dressings that were used in SJ and TEN. As you can see, a lot of them have used favor the biosynthetics and the silver impregnated. Here are the dressings, and some of them here are some of the brands. Some of the brands are already available here in the Philippines. So the simple cotton gauze, it's very inexpensive, but the problem is it can adhere and macerate, and you have to change the dressing frequently. And on a patient of SJTEN with eroded areas wherein you have to change frequently is traumatizing, right? Hopefully that we reduce the pain. That's one of the goals. Biosynthetics such as the silicone based, the silver impregnated, those are the ones. With the silver, the ones that are nice is because these synthetics, you decrease the application time, but they're costly. The silver decreases the risk of infection supposedly, and of course decreasing the wound dressings also. However, there is conflicting evidence regarding silver toxicity, but so far in most centers they somehow are in favor of using it. So the studies on dressings with SJTEN is problematic in the sense that, a little bit of sample sizes. The use of systemic medications is also there. The time of diagnosis to the time of placement of the dressings are also there. And of the lack of the studies comparing two or more wound interventions. So therefore, further studies is warranted if they really do influence the healing time. But they are now really part because of these reasons. They offer the advantage of reduced number of dressing changes, which improves the patient comfort, decreasing the pain problem of these patients. However, we do not know if they do have apparent impact on the healing time. That is yet still to be discovered or still to be talked about. But nonetheless, there's not much adverse events related to the dressings. This is just an example of one center who actually have their protocol. So this is their SJTEN. They based it on the percentage of epidermal detachment and the drainage volume. For this center, 20% is their threshold. So if you have less than, you might want to leave it on your epidermis or manage it with some of your wound dressings. If you have more than that, then probably some form of surgical debridement might be needed, but you will need biosynthetic dressings or other dressings to cover. For the drainage, of course, mild to moderate drainage or moderate severely drainage, here are some of your sample dressings that you can also think about in using. So with that, as we do all of these for your wound healing, the wound concepts, even in SJ and TN, we try to do that because we don't want these particular problems to occur, your post-inflammatory skin problems, as well as the scarring. So with that, I end my lecture, and congratulations and thank you for the invitation.
You may now proceed to our Sunset Symposia. Please go to www.tiktok2021.com and click on the room you would like to join.